So women are more susceptible to dementia, and we see this observationally. We see that in 2/3 of all the people with it, it's women, but we don't know exactly why. What we do know is that if a woman has her menopause early, either naturally early or through a hysterectomy, bilateral oophorectomy, she will also get dementia early. Alzheimer's dementia, which is 2/3 female, and the first person ever diagnosed with Alzheimer's disease was a woman, is the hippocampus. It shrinks first. The rest of the brain's fine, but the hippocampus, which holds our memories and our capacity to form memories, is the first thing to go, followed by the memories, as that hippocampus shrinks to nothing. Inflammation happens when the brain's not happy with something, or your skin's not happy with something, you get inflammation. And all of these diseases we're talking about, they're really inflammatory. Estrogen is an anti-inflammatory. So it is caught up in so many aspects of being female. Our immune systems are completely different from men. All of the inflammatory diseases are more in women because we've got this really complex immune system that can do amazing things, really. I don't know how I'd design it to both expel and grow something foreign. It's very complicated, and we know complex things can go awry more easily. I just wish the world would come together in the understanding that there is clearly different pathophysiology in women and men.
Welcome back to the Women's Handbook podcast, where we discuss everything women's health from menarche to matriarchy. I'm Dr. Natalie Hutchins, and today we're talking about brain health. Now, for too long, women's health has meant just reproductive health or just maternal health. And of course, it goes without saying that those aspects of women's health matter enormously. But women are not just walking reproductive organs. We are whole people with hearts and bones and brains that deserve just as much attention. I think for most of us, the prospect of losing our brain function, the ability to think for ourselves, to recognise the people we love, to do things we enjoy, and then to become completely dependent on others for our basic needs is just so frightening. And the reality is that dementia is a women's health issue. So 2/3 of people living with Alzheimer's are women. Alzheimer's is the leading cause of death for women in many countries like the UK and Australia. And yet a significant proportion of those cases are preventable. So this is definitely something we should be talking about so much more. So to do that, I'm really thrilled to be joined by Professor Cassandra Szoeke, a neurologist, author and principal investigator on the Women's Healthy Aging Project. We're going to be talking about women's specific brain health, what really happens to our brains at menopause, and what we can do to stay as healthy and as independent for as long as possible. So let's get started. Thank you so much for coming on today, Cassandra. It's so lovely to have you here.
It's great to be here.
In my introduction, we talked about the fact that Alzheimer's in women is just so incredibly common. I think lots of people will be quite surprised and shocked and quite frightened to hear about that. What is it about being a woman that makes our brains so susceptible to these diseases of aging?
Oh, wow. Well, that's the million-dollar question that no one has yet answered.
Okay.
And why is that?
Yes.
Because, in fact, they recruited everyone into dementia trials over 70 years of age.
Right.
Because it is basically impossible to get Alzheimer's dementia before 70, because if you get it before 65, you're literally called young onset dementia. It's a different sort of pathology.
Right.
So to get Alzheimer's dementia, which is known to be the most common type of dementia, although we now know it's actually mixed dementia, which has both the Alzheimer's, which is the amyloid protein, but also vascular changes as well. The mixed dementia, most common type, happens after the age of 65.
Got it. Okay. So you mentioned a couple of diagnoses there. Just for viewers that might have heard of these terms, but they don't actually know exactly what the diseases are, just explain the difference between Alzheimer's dementia and vascular dementia.
So vascular dementia is separate again from vascular disease in the brain. So mixed dementia means you've got Alzheimer's dementia, which is said to be the most common type. That's where you hear about this amyloid protein, and people with Alzheimer's dementia by definition have amyloid in their brain. But it turns out now that we're getting a lot of brains donated after people don't need them anymore, when we have that, we find that actually everyone's got vascular damage in the brain.
Right.
Vascular dementia is something else again.
Okay.
And that is where you've had a blood vessel blockage, which has reduced oxygen supply to the cells. Those cells have died, and the death of those cells leads to shrinkage or atrophy, and that leads to a type of dementia.
Okay, so that's a little bit like having a heart attack, but just in the brain.
Of the brain, yes.
But that's different to what you're saying is happening in the mixed dementia. That's amyloid plus a little bit of vascular damage.
Plus a little bit of vascular damage, which isn't like a little mini stroke. It's more like just generalised lack of blood supply to the brain.
Okay. So lack of research is kind of ubiquitous in women's health. We know that. But what do we know about why women are a little bit more susceptible to dementia?
So women are more susceptible to dementia, and we see this observationally. We see that in 2/3 of all the people with it, it's women, but we don't know exactly why. What we do know is that if a woman has her menopause early, either naturally early or through a hysterectomy, bilateral oophorectomy, she will also get dementia early. She will also get heart disease early. And as I said to you, the heart is responsible for pumping the blood around the body. If you have some problems with heart, you also get problems with blood supply to the brain. So really, these diseases of aging are quite overlapping.
Yes, absolutely. I want to get into the whole menopause and dementia kind of stratosphere in a minute. But just to go back in terms of the kind of the causes or the risk factors for women, obviously we know that a lot of dementia can be prevented, or a proportion of dementia can be prevented.
Yes.
Is there something specific about the way women live their lives that is causing some lifestyle risk factors, and that's the reason why women get it more? Is it something that's genetic? Is it that we have more preponderance of the ApoE allele? What's going on there, do you think?
Yep. So I can answer these questions, but usually as a doctor, you need national guidelines, big Lancet papers to answer questions.
Absolutely.
So the Lancet did a commission on prevention of dementia. I think it was 10 years ago was the first one. They've done 4 since. Every time they do one, I write to them and I say, why haven't you done it by sex?
Yeah.
Right?
God.
Because their risk factors are physical activity, nutrition, hypertension. These are also gendered, very much so.
Yeah.
And so I keep saying, and plus 2/3 of dementia is now known to be women. We understand.
Yeah.
And so to this day, those big papers have not looked by sex to tell you whether there are female-specific risk factors. Of course, because this is my field and I've done a lot of work in it, I can tell you what they are. I just wish the world would come together in the understanding that there is clearly different pathophysiology in women and men.
Yeah.
And the heart people, they've gone and done it.
They have.
They can see that 80% of male heart disease is macrovascular. That means the big vessels affected. So, you can bypass those. Easy. You can put a little basket and blow those bigger to get rid of the blockage. And you can even replace the heart if you really need to. However, the 80% of female heart disease is what we call microvascular.
Yeah.
That means if you're watering your garden, which is the heart, it's not the big tap vessel, it's the tiny little vessels all through, and you cannot bypass all of those.
Absolutely.
And so all the treatments we've tailored for male heart disease don't work in women, and we have to start looking at that. And that's really well understood. Now, the brain is all microvessels. So we have some big vessels going up our necks, but once it gets into the brain, they're all microvascular structure.
Yeah.
So we know women, 80% of women get microvascular heart. We probably have microvascular disease.
Yes.
So this is one component that makes us more susceptible because we don't have big vessel disease as much as we have small vessel disease.
Right.
And that is something that impacts the brain more than anything else because every one of your brain cells needs oxygen 100% of the time.
Yes.
And if any of those little vessels are having trouble, then those cells are not going to get the oxygen, they're going to die.
Makes sense.
And so that's one thing. The second thing is hormones. So women are completely protected for heart disease actually as well when they're pre-menopause. And once estrogen's removed, they actually get heart disease and dementia. And we know, as I said, if you have an early menopause, you have an earlier dementia, earlier heart disease. So we know these risk factors. So again, it's the type of disease, the pathophysiology and the estrogen. And then you get to other factors.
Yes.
So you're saying like we're talking about physical activity, things like this. So we did this great study in Australia, more than 20,000 Australians, representative of the whole of Australia. And we were looking at the so-called national guidelines and seeing how adherent people were to the national guidelines because they never do what they're told to do, right? But it's not fair when the government tells you to do something that's not really relevant to you.
Absolutely.
So what we found was that less than half the women had a healthy weight. We found that less than 30% of them were doing enough activity. We found that less than 20% of them were eating fruit and veg. And like we've got lots of fruit and veg in Australia.
Absolutely.
And, we're a land girt by sea and all our population lives on the coast. The politicians live in Canberra. No, they don't live in Canberra, but they go to Canberra. But all the rest is kind of around the oceans. And less than 10% were getting enough fish and legumes in their diet, even though it was the recorded activity. And you thought, well, what's going on, right? But interestingly, they gave the right serves of fruit and veg and fish and legumes to their partner and to their children.
Yes.
So there is something else in this. It's not that they don't know. It's that we've given women this perception that you got to do. Have you done your breast check today? Let's do it again. But we don't have to look after our hearts. We don't have to look after our brains.
Absolutely.
And yet the leading causes of death are heart and brain and heart.
Absolutely. It's what you talk about in your book. It's going beyond bikini women's health. It's about, the fact that we've got brains and bones and hearts that need looking after, and it's not just about our reproductive organs. And actually, we need to get women thinking about, I think if you ask lots of women, in fact, I think Time magazine often put this on the front of their magazine, that if you ask women, what are you going to die of? They'll say breast cancer. And actually, no, it's not. It's either
in
heart
Australia,
disease.
It's not in the top 10.
Exactly. It's either heart disease or it's, dementia.
And stroke is third.
Absolutely. Absolutely. And it's just getting that message out there that actually all of those things that you're doing for your children and your husband, you really need to do for yourself as well.
And I think, you can understand where it came from when we thought, men get strokes and women get strokes, and there's information on how to stop heart disease, there's information on how to stop strokes. But actually that information is not tailored for women because we have different kinds of disease, this microvascular versus macrovascular. So just to give an example, when you look at your lipid profile, everyone's like on their lipid profiles nowadays, and you've got the cholesterol and the low density, the LDL, lipoprotein, which is what tends to give you that macrovascular heart disease. But in fact, having a good cholesterol, which is the high density lipoprotein, the HDL, having that high is really good for microvascular.
Right.
So women, it turns out, their big risk factor is HDL, not the LDL cholesterol.
So interesting.
But remember, 20% of women get male type heart disease. So if you've had a heart attack and your cholesterol's high, don't change anything.
Absolutely.
However, what drug can you take for HDL? There's so many drugs for LDL cholesterol, but no one ever developed one because no one knew that HDL was such a problem. Now that we know, and as I said, the heart people are ahead of the brain people, they're going to be developing drugs for these sort of things. So we actually need different treatment because it's a different pathophysiology.
Absolutely. And just like you're talking about with heart disease, that it presents in a slightly different way as well in women versus men. I understand that actually dementia can actually present in a slightly different way. Is that true? And can you speak to that a little bit?
So again, it's sometimes people go, men do this and women do this, and it's sort of true to, as everything is true to a certain extent, it's the microvascular versus the macrovascular. So sometimes you get a bit confused because men can have 20% of men get this microvascular. They're also really tired and short of breath. But 80% of women are presenting with that, and we're expecting to see the macrovascular, central crushing chest pain, radiating to arm or jaw with shortness of breath. That's what we're expecting. That's macrovascular. And 80% of men have it, 20% of women. But for 80% of women, it's this micro, little bit of the garden, a little bit dry. So they're just like, I'm so tired. And the GP will say, well, are you doing a lot? And you're like, oh, well, actually, now that you mention it. Right? And women are so quick to say, oh, I'm just stressed, it must be this. Yes, there is a lot going on in my life. And that's why I often tell women to go with a friend. Because they will say, I've known Cassandra a long time. She's always been busy, but she's never been tired like this. Because sometimes we can't say it for ourselves. Sometimes we're so quick to discount any symptoms we have. But these are really significant in women because it is this insidious Microvascular, you're just always, your heart, your brain's always thirsty for oxygen. And if it doesn't get it, it says, I've got to lie down. I haven't got enough.
Yes.
But it's not that cataclysmic pain.
Got it.
Which is when someone cuts off your oxygen supply, you know about it.
Absolutely.
And so it's actually pathophysiology. It's not the way men and women think of things.
Got it.
It really is pathophysiology.
Yes. And what about with dementia, though? I understand that women will actually present more with things like depression and anxiety, whereas men might present more with agitation and things like that. Is that a difference in presentation that you found?
So when you look at the statistics, men are actually more likely to get vascular type dementia.
Got it.
So vascular dementia tends to be in the zones where there's the greatest blood supply, where when you don't get it, you're most likely to have a deficit. So that's often in the frontotemporal regions. The front is our personality. So often they'll say that men are more likely, but it's because they're getting a different type of dementia again, which is a vascular, pure vascular type.
Yeah.
And if it's in the front, then they're going to present with personality changes.
Right.
Alzheimer's dementia, which is 2/3 female, and the first person ever diagnosed with Alzheimer's disease was a woman, is the hippocampus. It shrinks first.
Right.
The rest of the brain's fine, but the hippocampus, which holds our memories and our capacity to form memories, is the first thing to go, followed by the memories, as that hippocampus shrinks to nothing. So again, it's pathophysiology. It's just we're having different types of disease.
Got it. Now, let's move on then to talking about how menopause and a reduction in estrogen actually affects our brain. Because you talked there about a shrinking in the hippocampus. And there was this recent UK Biobank study which showed actually that there is a grey matter loss in the hippocampus, which kind of mimics in postmenopausal women, which kind of mimics some of the symptoms you get, or some of the signs or the structural changes you get in Alzheimer's. There were some criticisms of that study, the fact that it wasn't longitudinal, but I wondered what your thoughts on that was.
So this is what's so difficult when we're talking about a process, and we're very proud of this as Australians because we wrote the paper that says Alzheimer's disease with the amyloid accrual, from minimal amyloid accrual to the kind of amyloid accrual you see in people with Alzheimer's takes 30 years.
Right.
Not a decade, not 2 decades, 3 decades. So mean age of onset of Alzheimer's disease is about 70. Minus 30 years is 40.
Yes.
So what study has been going from 40 to 80 to show you the chicken and the egg and work all this? There's no study.
What about the WAP?
Yes. That's why you're talking to me, and why I became famous overnight, just because it's actually the participants who have stuck for 30 years saying, I'm going to improve women's health. So the Women's Healthy Aging Project is a study that was actually originally started as a 5-year study by a psychiatrist. Back in the 80s, she got funding for it because she was seeing a lot of patients who were referred to her for midlife crisis. And she felt there wasn't so much psychiatry as there was pathology, like physical pathology. So she partnered with this amazing man, Henry Berger, who's an endocrinologist. He said, I'm going to run all the hormone panels of every hormone, because we know there's a beginning to menstruation. So let's run all the hormones and have a look. And she did all the anxiety and depression measures. And they brought in an epidemiologist, John Hopper, and together they built this study for 5 years to look at the menopausal transition. And they actually defined the menopausal transition.
What, the straw guidelines and things like that?
So the WAP study was the first, and it defined menopause under Henry Berger as this is the change. Then straw was funded. So at the 6th year of this study, after that 5 year, the straw was funded, and funded really well, A, because it's the US, but B, because what the 5 years funded study said is they haven't finished menstruating. It doesn't take 5 years. Turns out it takes more than 10. And so, of course, we were funded another 5 years to see when this thing ends. And it still didn't end at the 10 years. And then straw started. And SWAN started, which is the US study. And together, the SWAN and WAP data we combined to make the STRAW criteria.
Gosh,
Because they're the two studies in the world with the biggest data sets.
longitudinal,
Yeah,
yes.
and there was some other data, but the biggest longitudinal data sets.
Okay, so what
came
does
from that.
WAP tell us about what happens to a woman's brain for that woman who goes from premenopausal all the way through her menopausal transition, looking at her brain longitudinally? What do we know?
So we do see these changes, but I think the first question is, what do changes mean? So there's been a lot of panic. There's around the new study looking at pregnancy and saying, oh my goodness, look at the brain changes through pregnancy. These poor pregnant women are panicking. You got to remember that there's a reason people go to the gym, okay? Because if you go to the gym and you pump this muscle right there, that one's going to get bigger. Mm-hmm. The human body's remodeling all the time. Send an astronaut to outer space. We just did. Yeah. Their bone mineral density actually drops because they don't need to resist gravity. The body's this quick. Yeah. It's like, oh, what? You don't need to carry your own body around anymore. Well, there's no need for dense bones, is there? Yeah. And they get what's called astronaut osteopenia. Yeah. They literally use – so we're forever remodeling. Mm-hmm. So we have to look at remodeling and decide, is this remodeling, which is direct neuronal loss that's progressive? Dementia is a terminal diagnosis. Yeah. It is progressive, it keeps going, and it ends in death every single time. Mm-hmm. It's terminal. Or is this remodeling where when you become pregnant, your brain's saying, okay, you no longer need to do that, and by the way, you need to do a whole lot of this. Yes. And so we're going to redistribute the pattern of cellular uptake and performance to target the job that we are now doing. Yeah, so it's the brain becoming more efficient in a way. It's like what happens at adolescence as well. You get synaptic pruning. That's right, exactly. Some connections are strengthened and some are just pruned away. And so when you look at healthy aging, you also get pruning. Right. Because there are some things you're doing that you're no longer doing. And also we do see with everything in the human body, hence going to the gym, if you don't use it, you lose it. Absolutely. If you don't use your bone density, you lose it. If you don't use your muscles, you lose them. And if you don't use your brain, the brain will say, oh, well, you no longer need to do that, so let me put the resources elsewhere. Yes. So it's really important that we stay mentally active as we get older to maintain that brain function. Okay. So you talked about the alarm there with that study, and I think lots of other, in the media recently talking about menopause and the connection between dementia. You've obviously said that there is a connection, but what is that connection? Because it's obviously not that every single woman going through menopause will end up getting dementia. Is it just that menopause kind of displays a vulnerability to getting dementia? Is it just certain women? Because a lot of women will get cognitive symptoms when they start going through the menopause. They'll get brain fog and memory lapses and, difficulty with recalling words and things like that. But they tend to resolve in lots of women. Oh, absolutely. Yeah? So we have got to separate those symptoms of menopause from dementia. Okay. So there's lots of women, when they start getting that, will think, oh my God, I've got dementia. And particularly with all of this in the media, they'll go, oh, well, I really have, because it can happen. My brain can shrink. This is what's happening. And that's not necessarily the case. No. So one of the things we've done when we've been trying to refine these really brilliant cognitive tests that don't, like the old ones, see what part of your brain is damaged, but instead can actually pick up really small changes, nuanced changes. So they're really quite cutting edge on your cognitive capacity. We see that if there's a noise somewhere, their cognitive test score dips. Right. If there's any distraction, any attentional issue, if they're having a bad day. Yes. So mood, depression, anxiety because of the distraction, and depression because of the depressed mood, you literally, there's a form of depression which leads to what we call pseudo-dementia. It's such a bad depression that in the testing you come up with the same numbers as someone with dementia. Wow. But that one's entirely reversible. It's not terminal. Okay. If you treat the depression, but it's called pseudo-dementia because it looks exactly like dementia. So that's the cognitive and mental health overlap. It's huge. Yeah. So you've got to remember all these things. And that must be more common in women as well, because women tend to get more depression. They do. And look, around the menopause, you're getting distractions. Yes. You're getting attentional issues. And here's the big one. The biggest thing of all those things I mentioned to you, if I really want to drop your cognitive score and fake a result, I'll cause you pain. Right. Any pain. And I don't mean you think, oh, you're going to stab me. No. If you need to go to the loo, just that kind of like you're not running off, but when this is finished, you're going to go, that sort of, that's not even what we would call pain.
Yes.
That drops a person's cognitive score more than when you're playing a trumpet in their ear to distract them.
Wow.
So look at menopause and aches and joint pain, hot flushes.
Yes.
The distraction of these symptoms. So I think when we talk about brain fog, it's absolutely there, but that's not necessarily pathological.
Okay.
It is to do with cognitive performance is optimized and optimized. We've got to be silent, got to be this, got to be that. And we're not optimized around the menopause transition, so don't stress about it. But the leading cause of death in UK is dementia. So there has to be some element of concern, and we know that estrogen is protective. Okay. And it's not like it's just protecting your brain cells. Yes, brain cells have got lots of estrogen receptors, but it's all connected into the oxygen supply that's coming to your brain and the microvascular damage, which again, estrogen protects from the microvascular damage. Yes. Which is why women get heart disease after. And also, when you're looking at the protection of estrogen, it affects everything around the inflammation. Right. So we're starting to understand that Alzheimer's, yes, amyloid is there. It's always there. And people say, it's poisoning the cells, but then they ripped it out and it didn't make people better. So like, maybe it's not poisonous. It's definitely a marker. Yes. It is there when there's a problem. In fact, we have amyloid in our tears because it helps against inflammation and infection, really. It's an anti-infective agent in places where we're kind of exposed to infection. Got it. So it looks like it's there because the brain wasn't happy with something. Inflammation happens when the brain's not happy with something or your skin's not happy with something, you get inflammation. Yes. And all of these diseases we're talking about, they're really inflammatory. Yes. Estrogen is an anti-inflammatory. So it is caught up in so many aspects of being female. Our immune systems are completely different from men. I mean, all of us, men and women, we get a little splinter, a pus ball forms under it, even if you don't touch it. I know we take them out, but if you didn't touch it, it will literally push that splinter. The body will exude that splinter and heal over. Yeah, pretty amazing. Anything foreign in us, tiny little piece of wood, will be expelled. Yes. Where women differ is they can do that, but they can also keep something far more immunogenic than a splinter inside them, not just not expelling it till it's time, but also growing it, feeding it. Yes. So the complexity of that immune system to be able to say, I reject anything foreign except this, which I'll grow. Yes. Is a whole other world of complexity, and no one's quite ever looked at that. Absolutely. Although we all know that women have more MS, inflammatory condition, they have more rheumatoid arthritis, inflammatory condition, that all the endometriosis, all of SLE, Sjogren's, all of the inflammatory diseases are more in women because we've got this really complex immune system that can do amazing things, really. I don't know how I'd design it to both expel and grow something foreign. It's very complicated, and we know complex things can go awry more easily.
Okay, so if we know that estrogen does all these amazing things in terms of reducing inflammation and keeping our vessels healthy, then obviously the logical step is to say, well, of course, HRT for all women, and that's going to reduce our dementia burden. What do we see with that?
Okay, so this is what happened. First of all, they said, well, absolutely, if we take out someone's ovaries, we are going to give them replacement until they get to the age of natural menopause, because we know if we don't, they get heart disease and dementia really young, right? So that was a no-brainer, and that still happens today. Yeah. What occurred is they said, but we've got to prove this, don't we? So let's do a trial where half the people get hormone therapy and half the people don't. And then we're going to follow them up, and then we're going to see who gets heart disease and dementia. The thing is, oh my God, there's some primary things. So the first thing to say is when they did this, because it's actually a way of doing things where you're a little less flexible and you say, I need to control everything. Yeah. And how do you control all the things I said were prevention, like nutrition and physical activity? And you can't randomise control trial that. Of course. And they're trying to randomise control trial it. So if you came into the study, said, I'll go in your study, and they said, okay, have you ever had hormone therapy before? And you said, yes. Well, you couldn't be in it because that's not random. And if you came to the study and said, oh, yes, I'm menopausal, I've got hot flushes, I'll come in your study, they said it would be unethical for you to come in because you have hot flushes, you should be getting hormone treatment.
Yeah.
So we can't have you. Hot flushes, by the way, is a risk factor for dementia and heart disease. So the people who were at risk were all excluded from this study, just FYI. So they're all excluded. So at the end of the story, and I won't belabor it, but at the end, what you had was women who were over the age of 60, mean age over 60. They were a mean decade, not a mean decade past their final menstrual period.
Yes.
So they had washed out of estrogen down to, we can only detect it with the high sensitivity assays. And then they were randomised to get this estrogen.
Yes.
So if you've washed out of estrogen and your hormone profile looks identical to a male's, don't start taking estrogen because it can be prothrombogenic.
Yes.
And then we go to the type of estrogen used. So a lot of people know that was conjugated equine estrogen. That was when we used to gather it from pregnant horses, mix it all together. So you had about 12 or so horses in every vial. And when you swallow that, humans are a little bit allergenic to animal products and we're more likely to clot.
Right.
So the type of estrogen was also more likely to clot. And what they found after 5 years, by the way, how long does it take heart disease? Decades. How long does it take dementia? 3 decades. After 5 years, they found that the people who were taking it were more likely to get breast cancer and they were more likely to get clots in the legs.
Yeah.
And much less likely to get osteoporosis. Like it's a panacea for osteoporosis.
Yes.
And they said, oh my God, clots and breast cancers, stop the trial.
Yeah.
And everyone stopped their estrogen. And then there was a lot of debates and discussions and it took 10 years. So 2002 is when that came out. 2010 was the first time people started stepping forward going, but what about the timing?
Absolutely.
What if we just maintained estrogen instead of washing out and bringing it back? Unfortunately, the dementia arm of this trial, I just told you that people usually get dementia over 70. So if you're going to run a 5-year trial, what age do you want to recruit? So I told you the people in that trial were a mean age of, they were 75 in that because they had to see cases of dementia. And so, yes, they found that if you're 2 decades post FMP and start taking estrogen, it does not reduce dementia. It may even increase it. Is that relevant to a woman who's 45?
Not at all.
We don't know. But we also don't have the 30-year study that I can definitively say to you, there's been a randomized controlled trial and this and this and this. What we can say is the New England Journal of Medicine just published. Tiny trial, because you understand the patent's gone of all these medications. So that 50 billion they spent on that initiative is never going to be respent. So much smaller sample size. They took women at 45. They gave them hormones or not. And in 5 years, you're not going to see heart attacks in 50-year-old women. You're not going to see dementia. But they measured their vessels and they saw the ones on hormones had better vessels. And now everyone argues, but does that mean they would, I know what I want my vessels to look like, but I cannot definitively tell you at a level, what we call level A evidence, which is the randomized controlled double-blind trial. And this is where we get trapped in that's why we don't have healthy aging. Every chronic disease that takes 2 to 3 decades, there is no randomized controlled trial that's gone for more than 5 years.
Yeah, it's just almost criminal. But what about the Women's Healthy Aging Project? Tell me about that, because obviously that's been going, as you said,
yes, but
since
it's not
90s.
It's not a randomized controlled trial.
No, it's observational.
But we see it is, and you like to be observational. Guess what happened in 2002? Every woman stopped her hormone therapy.
Yes. Right. So because of that, I understand. Yes, of course. Okay. So actually you didn't have those numbers that actually maintained on the
Well, look, we do
therapy.
have it, but it's a small sample size. So I can tell you, yes, that's what we've shown. We've shown better cognition. We've shown these things, but it's in a small Australian sample.
How many women who stayed on it?
500. Oh, no. So 500 women all up.
Wow.
And, of course, 25% take hormones across that time.
Yes.
So the samples, when you've got Women's Health Initiative 50,000, this is the other trouble when they say they've done meta-analyses. And when you've got 50,000 patients in one study and 200 in another, and the new ones only got, I think they had 500 in the new one, the 50,000, whatever happened in them is going to change all the data.
Yeah.
So they have actually acknowledged that and stopped doing it because it was the wrong methodology.
Yeah. So your feeling is, and what I'm getting from you is that your feeling is, yes, I don't have the randomized controlled data. I don't have that 30-year study, but my feeling based on the mechanism of what's going on in the brain, what we know estrogen does for both the heart and the brain, is that if we did have that long study.
What I can definitively say is if we didn't have menopause, there's no suggestion we'd ever get those diseases, actually.
Right.
But, I mean, we've never trialled that. But, you know, if you didn't have that, because it's related to that FMP date, all of the diseases are related to the FMP date. You asked me about genetics.
Yeah.
So ApoE is a risk factor in both men and women. However, women who hold that allele have 4 times the risk where men have 2 times the risk.
Wow.
So there is like a worse risk in women, but is that because they're more likely to get it? Because they've got 10 things going on, not just the gene.
Yeah, absolutely. Okay, let's move on to prevention. Tell me what your top 3 things are lifestyle-wise. If someone's sitting here today and say, look, I'm worried about my dementia risk, what would you be telling them your top 3 things to change in their lifestyle?
Okay, so the Lancet Commission has done this and they've got 12 things that you can do.
Okay.
But they also have hearing loss on there and chicken and egg. So I told you if you don't use it, you lose it.
Yeah.
And if you're not hearing conversations, you tend to be a bit out of conversations. And then, so I don't know whether that's a risk factor or associated or even an early symptom.
But do hearing aids not protect you from dementia if you've got
So
hearing
you'd
loss?
need to have a randomised control trial where
And
you
there's
go
not been done.
Well, you can't say to someone, I'm going to let you not hear
Of course,
and randomise
of
double blind.
course.
That's awful.
Of
This is what I
course.
mean. When you're dealing with complexity, we
Yeah.
have to move away from that level A evidence model.
Yeah.
And anything lifestyle is not randomised.
Yeah.
I'm going to make you exercise and I won't, and neither one of us will know what we're doing. Yes, we will.
Yeah.
It's very complex. And aging is complex. It's all about multimorbidity.
Absolutely.
So if we want to crack the nut of healthy aging, we have to change this model of complete control because
Yes.
humans can't be controlled.
Yes.
I mean, some of the jokes in medicine are that in the trials, they have full compliance with the medications. And all the studies done 100,000 times, there's not compliance, not near 100 compliance. It's about 70% compliance with medications if you
Yeah.
look at an individual. So, they're still working at 70% compliance. It's pretty good.
Yeah. So tell me the top 3 things.
Oh,
Lifestyle.
top 3 things. Oh, yeah, 100%. Okay, so I'm going to do this for women because you
Please.
can look up the Lancet
No,
Commission
we
if you want for everyone.
we want women.
So this is for women and it's very different actually.
Okay.
So the number one thing is the same for both men and women and it's physical activity.
Okay.
It's the number one thing to do. Don't freak out. You don't have to go to the gym. An hour of activity every day. Pick something you love because you've got to do it every day for 40 years.
Yeah.
And then you won't get dementia, so you'll still be alive. You've got to do it for 50 years.
Now, whenever anyone talks about exercise and physical activity on the internet or social media, it's always about, getting your VO2 max up. It's about doing the portfolio. Yeah. So what are we talking about?
So it's any activity that you would like to do for 1 hour a day, every day.
Okay. We don't need to think about what our heart rate's doing. We just need to just do it.
You just got to do it for 1 hour every day.
Okay.
Now, I can give more detailed advice, which is, yes, you got to do. You'd like to, in that 1 hour, you want to get your VO2 max up, but that's just one tiny aspect.
Okay.
You've got to do resistance training. You've got to do balance. People never, and that's far more, and people are dying of falling over far more than they're dying of
100%.
VO2. In fact, sometimes VO2 max ends up as cardiac arrest.
Yes.
So, in a funny way.
Yes.
So there's all sorts of different exercises we should be doing to be optimum.
Yes.
But balance is right up there, and resistance training to get out of a chair literally
Yes.
is way more, ask anyone old, that's way more important to maintain your balance and your ability to get out of a chair than anything else. Getting out of a chair predicts your death.
Yes.
So that's really important. It's number one, it's for everyone. Number 2, for women, is to have good blood pressure.
Yes.
Women and blood pressure. Blood pressure is a silent killer of most women. Here in Singapore, your leading cause of death is heart disease. Your highest rates of risk factors. You have smoking here. Who's smoke? We don't smoke here.
Oh, yeah.
In Australia, we go, how people, it's
Still
like
do.
smoking? What?
Yes.
And high blood pressure. So, we've really got to look at our high blood pressure. The other problem, it's not a problem with women. I was just about to say the other problem. Oh, my God. The other problem is that when men have a high blood pressure, it'll be a high blood pressure and it stays.
Yes.
Women have what we call hypertensive variability. So it'll go, whoa, whoa, whoa. And it'll always be high,
Yes.
but it can go really high.
Yes.
So sometimes you'll be in the office and the doctor calms you down, and because he takes it as too high. Oh, okay, you better calm down. And you can calm it down.
Yes. And they go, oh, it's white coat.
Yeah,
hypertension.
that's okay. Oh, we might just watch it. But actually those women are hypertensive.
Yes.
Most of the time.
But will that be picked up if they did a 24-hour blood pressure monitor?
Yes, it will. And everyone should have one of those.
They
I
should.
highly recommend for women.
Absolutely.
So it's your hypertension, and get that 24-hour monitor.
Okay.
Even if they
Exercise.
say it's borderline, because we've got great treatments for high blood pressure, and
We
they
really
actually, thank God, work in women as well as men.
Absolutely. Okay.
And then the third one is when they talk to you about your lipid profile and watching your cholesterol and LDL like a hawk, watch your HDL.
Yes.
Women must have over 1 high density lipoprotein. You've got to have that, and then you're going to be protected. Those are the top 3. And, cholesterol and LDL do matter for women, but when we did our studies, the cholesterol and the LDL are, of course, directly correlated with the HDL.
Yes.
So they do matter, but actually it's the HDL driving the relationship. They're just biomarkers because they're related to the HDL. So it's your HDL that's actually causing disease in women when it's not high enough.
Understood.
That's our good cholesterol. We got to get it up there. One of the issues is they're not making tablets for it because it wasn't a male thing, and that's where all the heart disease kind of came from. But 1, they're starting now, and 2, the way to get up your HDL, would you believe, physical activity.
Oh.
So I actually
Punchier for
wonder, I
everything.
told you for men, physical activity is number 1, 2. I wonder if I told you 20% microvascular,
Yes.
that's them getting their HDLs up.
Understood. That's really good advice. Okay, so we've got the things that you definitely would do. Can I just give you do a quick fire round on a few other things that are very popular in social media at the moment, and tell me what you think?
Oh no, I'm not talking about Trump. I absolutely refuse.
No, that we don't need to go down there. But okay, creatine supplementation, yes or no?
Okay, so any of the supplements have not been proven because you need 30 years data.
Yes.
And some of the ones that they say don't work, they did a 3-month follow-up study or they literally do 3 months of supplementation, expect to see a change. This is a disease that takes 30 years. So a lot of those questions are difficult. Also, we know vitamin D supplementation with calcium works great for bones. Turns out, so people who have low vitamin D are more likely to get MS.
Yeah.
People who have low vitamin D more likely to get dementia.
Right.
And we showed in our study they even have worse cognition, which was horrifyingly shocking.
Wow. Vitamin D is just so important for everything, isn't it? Yeah.
But all the supplementary studies haven't shown any benefit.
Okay.
And that kind of freaked us out because, but they're short and so on. But then again, we see even drops in vitamin D will drop cognition. So it really should have helped. And then we are now realizing vitamin D is not something we eat. I mean, I know you can get tablets, but in human beings, we actually get it from sun exposure. There is a compound in our skin. When the sun hits it, it converts into active vitamin D. Our body sucks it up. You can eat vitamin D. It's in eggs. It's in things, but that's not where we're meant to get it from. We're meant to get it from the sun.
Totally.
Now, it turns out that reaction in our skin is an anti-inflammatory reaction.
Right.
And we're all, in Australia, we do not want to get skin cancer.
No.
And sunscreen blocks the vitamin D conversion. So everyone's out of the sun. People are now working from dawn till dusk. Our whole environment is anti-sun. And so we're seeing a lot of vitamin D deficiency, and you can't eat it. They eat it, they get normal levels, but they're not changing this brain inflammatory disease.
How interesting.
Because I think it's this fundamental way we get vitamin D that's the sun's anti-inflammatory for us. Okay. But don't panic, because I've been in Australia, I had to go to the Cancer Council. Okay, help me out here. I have a message to give, but how do I give it? 10 minutes, forearm in the sun gets all the vitamin D you need a day.
Exactly. So there's actually no reason to kind of
compromise. No, because that will not give you, and why do I say
Exactly.
forearm? It doesn't have to be a forearm, but you can check your forearm, right? So I want little spots. What's that spot doing? And get it cut off early.
Totally.
So that's the advice. Do not expose your back.
Yeah, can't see that.
Can't see it.
Okay. All right. Another one that was circulating on social media: all women should be on a keto diet at menopause for their brain health.
I would not do that.
Okay. What is the best diet for brain health?
Oh, well, okay. So, oh my goodness. So the best diet for brain health, the most studied diet for brain health is the Mediterranean diet.
Yes.
But the DASH diet, there's 1,000 diets out there that basically are good for you and have shown benefit, but they're less studied because they're not as popular as that diet. That's always studied, okay?
Yeah.
I had a PhD student who looked at this beautiful work where they took all the diets. We did diet scores for every woman because we have a full nutritional survey.
Yeah.
They scored them Mediterranean, DASH, they scored them for all the different diets based on exactly what they were eating. And long story short, I could show you the graph. Everyone's eating the same stuff. It's like they're all shopping at the same shopping centre, except for a few exceptions. Okay. So when you look at this, you can see that the people who are getting ill are eating sugar.
Right.
And cakes and sweets, added sugar, and processed food, added sugar, added salt. Yeah.
Okay.
So stay away from adding sugar to your diet.
Okay.
Yeah?
That's a nice simple one.
You can eat anything, just don't add sugar.
Okay, good.
Yeah, and cakes obviously are pure added sugar.
Absolutely.
So minimise that. And processed food is a big one. People don't think of it as sugar. And it's literally sugar and salt in every processed food to be able to let it have a shelf life.
Make it be so palatable as well.
And then the people who are doing really well, they have big pings on fruit and veg, green leafy vegetables, nuts.
Yes. Okay. So
avoid that, eat that.
Really nothing special apart from the standard advice that we give people all the time for actually everything. So brain health, heart health, everything. Tell me your if you've got a woman out there who's going, right, I'm really interested in this conversation. I'm worried about my own risk. Maybe my mother had dementia and I watched her go through what she went through and it was awful. I really want to save that fate for myself. What's the number one thing you want her to do? Oh, the activity. Everyday activity and keep using your brain. People are like, oh my God, do I have to do crosswords? No, unless you want to be good at crosswords. They did all these brain training where they made them do crosswords, they made them do Sudoku. They got damn good, these demented patients doing Sudoku, But it doesn't change your risk of dementia, interestingly. But you know what does? Using all of your brain. Yeah. So people forget when they do Sudoku, they're only using visual and verbal and socialization. We use balance, we use movement, we use recognition, memory. Like we're actually using the largest parts of our brain when we interact with others because we have to get up and go somewhere too most of the time. Yeah. So that's probably the best thing to do that's an overall. Yeah. And if you can discuss current affairs except for Trump, then you're doing even better because you're actually intellectually also exercising that brain. So stay social and exercise. Yep. And the other thing I got to say is in 2000, the National Institute of Health mandated that females are included in all clinical trials, made a mandate. You can't register your trial if you don't show you've got half women. Hallelujah. Yeah, so 2000, they did it. However, they're not giving their results by sex. Right. However, when we started working out heart disease was different and dementia is probably going to be different too and clearly different because 2/3, people went back to the data set and said, well, can I have the data? Yes. And they've certainly recorded, and sorry about this, it's only binary gender, right? So that's what we're with. It's male, female, which means there's going to be some XX and all the rest of it. That's all we got. So looking male versus female, we have seen a massive exponential rise in reports of sex differences. Wow. It's doubled just in the last 10 years. That's so good. So we have so much knowledge I could give you today on how you would treat dialysis, how we would dialyse a woman versus like dialysing a man. I can tell you it's out there. They're putting it out there. However, Cassandra, you need to write another book. Doctors don't read books. No, I do. You need to write another one. What we need to do and what I've actually done, and it's launching in July, is a sex-specific health education course. Love it. It covers why we would do it. It covers, there's 4 units that will then give an accreditation that you're sex-specific. This is the doctor you want to go see, right? Yeah. And I want to offer it not just to doctors, to all allied health, of course, because the muscles, so I'm doing biology, structure. You know how actually the Olympics just stole my thunder with their recent, the muscles are different. Yes. And pharmacology, toxicology. Women have 4 times the rate of adverse drug reactions. And you'd think this is only information for doctors. Pharmacists, pharmacy students,
patience.
Yeah,
You know, like
absolutely.
everyone needs to
The
know this.
list
We need
goes
to
on.
upskill. The knowledge is literally there, but no one pays for education. No one let's do it. Hang on. 10 million you'll give me for this trial, right? But would you give $1 for me to tell everyone what's out there that could literally overnight, the lowest hanging fruit is women's health.
Oh, health literacy in women's health is the lowest hanging fruit. That's why I do this podcast. It really is. It really is.
And we've got to give the knowledge to women too, because they're their best
really
advocates.
Well, the thing is, if you don't know that something could be wrong, there's pointless. It's actually pointless educating us. If the woman doesn't know to come in and see us, what's the point? You know, they have to be educated. Absolutely. I completely agree. I have loved speaking to you. I wish that we could have had much longer.
Sorry, I got so rushed.
Not at all, but I'm just so grateful for you to come in. So thank you very, very much.
My pleasure.
And that's it from us at Women's Handbook Podcast.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.